Nancy. This is my Miss Nancy moment. Oh, awesome. Dave, so good to see you in Utah. Maureen in the UK. Ayal from Israel. Hello, Ayal. If everyone could take a little moment and put their name and location in their profile, that would be great, because then we get to really see the collective here of our international awesome contingent. So do you all know how to do that? 3 dots on the upper right. If you go into gallery view, if you want me to do it for you, I can, because I know you're on a tablet, I can tell. But the 3 dots, and then click on that in gallery view, go down and it'll rename. Thank you, Trisha. Hi, Trisha. Good to see you, Trisha O'Hare. Paula Kingsley in Seattle. So good to have you. So a lot of you are here, and part of you are active members of the AOMT, but what I'm really wanting to do is spread the love, so to speak. So every month we're going to have an open event, and this means that anyone who you think would be interested in what the speaker has to say, or if you have friends, depending on what they want to do on a Saturday morning, they can join us. So I'm really happy that we can welcome a very dear friend. And I say this because Steve Carstensen has been a colleague for many years, and I've admired his active role in building awareness around sleep medicine in the dental field and dental sleep medicine, going to every single meeting ever. I don't know what you do. Where are you? How are you functioning? Flying all over the world, collecting, sharing, and it takes a lot of energy to go to these events. So, aside from that, he's been a dentist for decades, and I actually would love to know what brought you into this. I don't even know exactly, Steve.
What brought me into sleep medicine?
Yeah, yeah.
Oh, actually, one of my mentors from dentistry, Keith Thornton, is in Dallas, and he was a teacher of mine down at Pankey Institute. And he and I bonded right away when we met in 1989. And as he became one of the founders of the dentist involvement in treating sleep disorders, he would call people close to him and say, "Man, you got to do more of this. This is so exciting." And, being my mentor, I followed his lead into it.
Wow, that's awesome.
Yeah.
And a lot of you are just getting into this as a myofunctional therapist. That's where I know you, but there's dozens and dozens of you who've been doing this for a very long time as well, in different capacities, in different roles. And the sleep element has put our fields into a medical arena. And so it's really interesting when we go to these meetings, the interdisciplinary information that's coming through. And so that is something that Steve just put together, as he does another fantastic meeting of the ADA Children's Airway event. He's going to talk a little bit about that and its conception and the role of technology, so we can really know how to assess and talk to parents with the tools that we have. And so, Steve, thank you so much for coming and joining our bright-eyed, bushy-tailed group. I love that we're here on Saturday. I don't underestimate this at all. It's so awesome. So welcome, Steve, to the Myo Coffee Klatsch. I hope you have your coffee, and we'll get going.
Oh, you can't. There it is. Wait a minute. The magic of Zoom, right? There it is. Yeah.
Oh, yeah.
Thank you, Samantha, for inviting me. Yeah, guys, your leader's an amazing person who does tons of things that are not really just related to what meets a individual goal. And that's kind of what we have to do is as groups like yours are the leaders of an area of healthcare that isn't really relegated anymore to one part of the profession. When I started with this, I mentioned Dr. Thornton, and we were dentists, and we are dentists, and the area was controlled by physicians back then because that's who defined sleep apnea back in the day. It was defined in hospitals. It was defined in overweight old men who were dying in hospitals because they stopped breathing. And the physicians were wondering what they could do to help these guys out and developed a whole field called sleep apnea and named a disease and found out why it was a problem. And but it was all in the purview of physicians. And they came up with a treatment for it, CPAP, back in the late 70s and became commercial in the early 80s, which is fine, except that even back then, people were rejecting that therapy, and and so dentists said, well, we got an idea. Actually, an ENT started, but then a bunch of dentists came along and said, we have an idea, and started holding the jaw forward, just like we learned how to do in CPR class. And that became a pathway for helping these adults take care of their airways back in just about the same time CPAPs came along. But we don't hear about dentists as much because the disease was defined by physicians, even though it's a mechanical problem of the upper airway in adults. And but the downstream problems, the cardiovascular disease, the insulin resistance, the inflammation, all those things are what physicians treat. So they said, well, we have this problem of the airway causing these medical issues, and so it's a medical problem. When really it's just a mechanical problem up the airway. So Dennis got started with this, and then so as I came along with Keith Thornton's mentoring, I became adept at making oral appliances to help hold the upper airway open so these people could breathe well at nighttime. Well, great. That's a role that only dentists can do, and that's an important role of what we do. And people like John Viviano, who's on the call here now, are pioneers of helping our colleagues learn how to do that. As we sit in our practices, as I said in my practice, and looked at my 40, 50, 60, 70-year olds and said, okay, fine, let me help you with your airway. I want you to sleep better tonight. I want you to not snore. I want you to not suffer from this problem. It became obvious as I was looking at them, being trained like we all are in looking at the craniofacial respiratory complex, that the problem isn't just that they sleep on their back or they're overweight or those things. The problem is the structure, the three-dimensional and fourth-dimensional structure, fifth-dimensional, if you want to think about adding time and function onto a three-dimensional bony structure. The problem is that. The problem is we're overcoming a mechanical problem. Well, where does that mechanical problem start? For my 40, 50, 60, 70-year olds, it started when they were 4, 5, 6, and 7. And now we understand even earlier than that, but that was the initial thought. And I thought, well, okay, great. If those adults are having these kind of issues, well, what about when they were kids? What about their kids? What about their grandkids? And I started looking around, and there weren't very many people in the middle 90s that were looking at children as part of this because everybody was focused in sleep medicine on how to treat adults. There was such a thing as a pediatric sleep medicine doctor, but there's still only a handful of them. And dentistry hadn't really opened up its eyes yet to thinking about airway issues all that much. And the American Dental Association came up with a policy statement, and we saw it develop. They had comment periods. I was part of the comment period inputs, and I was in Chicago in 2017, and my friend Glenine Varga and I were there recording for some promos for ADA for some conferences coming up. And we had some wine after our work, and we were talking about the policy statement and realizing, wow, this second paragraph out of 11 was all about kids and how dentists have the role to identify kids at risk, get a diagnosis, and then apply appropriate treatment. And the goal was to establish the optimum physiologic breathing pathway. And so, what a powerful statement. So we thought, how can we get this message out? And so Glenine and a woman named Dawn, who was at the ADA at the time, and I came up, well, why don't we have a conference about this? Why don't we tell dentists what to do with this paragraph? It had never been done before. And so that was in August of 2017. And I started thinking about how we could put this together and realizing there were some luminaries in medicine and dentistry and orthodontics and all these other fields that could be there for these little kids. And I said, why don't we put a conference together? So I went to the most important medical provider of them all, Dr. Christian Guilleminault, and I said, Dr. Guilleminault, would you come to a conference if I put one together? And he said, of course. We should have done this 10 years ago. I went to David Gazal, who's a very, very prominent sleep physician, researcher. Now he's a dean of a medical school. Dr. Gazal, would you come and speak? Of course, I'll be there. Everybody said yes. And so 7 months later, the American Dental Association said yes. It took me that long to convince these ADA trustees that, in fact, we should have this conference and stake our claim on dentistry as part of the solution for these little kids. Talk around the trustees table was like, well, why would dentists want to listen to physicians? What do they have to tell us? There was a lack of foresight. They didn't really understand how to deal with this. So we had this assemblage come together in August, and in on a Thursday all day in a conference with the trustees boardroom of the American Dental Association. I had those Dr. Gimeno, Dr. Gazal. We had orthodontists. We had no, there it is. We had pediatric dentists. We had myofunctional therapists, psychologists, physical therapists. We had everybody that I could think of was there. And these are the speakers that came because what happened is I thought, well, if we're going to have all these people come to Chicago to talk about what we can do for Kids Airway, how we can implement this paragraph, why don't we have a CE program that would take advantage of all these people being in Chicago? And so this is all the speakers but one. Dr. Gazal had to leave, but this group of people from across medicine was there. Mark Moeller, representing myofunctional therapy at the time, he flew back in from Europe just for this conference. And it was amazing to be there for that Thursday. And I think you probably recognize most of the people on there, but Dr. Mark from the left, Mark Cruz from California, that's Valerie Crabtree. She wrote a book called Pediatric Behavioral Sleep Disorders. She's a PhD psychologist who is also a sleep specialist. There's Dr. Christian Guilleminault, Dr. Stephen Sheldon. If you've ever seen Finding Connor Deegan, Dr. Sheldon was the sleep physician for Connor Deegan. Pat McBride from California, who's just an amazing force in sleep medicine. Kevin Boyd, you probably all know. Then Glenine Varga, who was my co-developer of this program, and she also wrote or helped me write the Children's Airway brochure for the ADA. And then the picture's gone away, so I can't remember who was next on the list. But there was a myofunctional therapist, and that was coming back. Oh, okay, there you go. Jill Umbrello is a general dentist in Dallas, Texas, who does a ton of work for helping kids, especially with behavioral aspects and functional aspects. And Christy Gatto, a myofunctional therapist, I'm sorry, she's a speech and language pathology who does myofunctional therapy. I called her a myofunctional therapist one time, and she virtually slapped me because she said, no, there is no such thing. She said, we're speech and language pathologists who do myofunctional therapy. We are hygienists who do myofunctional therapy. And then Barry Raphael, an orthodontist from Clifton, New Jersey, who's a spectacular educator as well, and then me at the end. So that was most of our speakers, but just amazing people. We had folks who were crying because we ran out of space to host them at the ADA for our 2-day conference. So out of that, we've created a number of things, including a screener program that we're trying to get validated so we can make a difference in medicine. So that's what it got started. But the key here is that it was me in this instance, but there's been other instances where people have identified a need and just said, you know what, why don't we just try something? Why don't we do something about it? And that's what people like Judith Denver Page and John Viviano and others on here have done. They've taken up the mantle, seen a different future, and said, what can I do to make that happen? And I'm not, and Trish O'Hare's on here. She's done that similar things. I mean, and I don't know all of you guys, but I would imagine that the majority of people on that choose to get up every Saturday morning and join a group of like-minded professionals like this all have instances in their past where they've been part of a bigger movement, and that's kind of what I'm trying to do. I see the effort being put out, my role is to help the American Dental Association keep this on top of mind. And they have a lot of things on their plate right now, so I'm fighting to keep it on the plate. But it's something we've done now for 8 years. We've had 8 of these American Dental Association Children's Airway Initiative talks, and Samantha's been part of several of them, I'm happy to say. And Kevin Boyd's been there for every one of them. Other pediatric dentists and orthodontists have been part of it as well. So we try and make this something that people who are interested in helping kids can look forward to every year as a way to get together and do something like what you guys do on Saturday mornings, which is in part reinforce the effort that you're putting in. Because it's easier to work hard when you know that other people are also working hard for that same kind of a goal. And we make differences in our communities and differences in our practices when we turn the kinds of learning and reinforcement we get from hanging out with our peers in a community like this. We make a difference in our community when we go back, but the very fact that we're gathering together makes a difference in the profession, makes a difference in the world as we consider what impact we have. So, big congratulations to all of you guys for that.
It's
On
great to see how many are here this morning. I just want to acknowledge it. It's pretty 111. That's a really significant number. And
wow.
so, I think there's a lot of interest, and sometimes we just don't know what role we play in this puzzle. So to hear other people share how they're doing things, it helps us define what our impact is and how we can work with patients, because we see it happening around us. So it's awesome to have you all here.
And when things like this kick off, then other people that are looking for a way to be different, looking for a way to contribute, looking for a way to make a bigger impact, join in. Milton Gabelis is here from Chicago. Milton, when you were a budding periodontist, you didn't imagine that you'd be being a leader in how to do tissue tie releases and working with a bunch of myofunctional therapy providers and speech and language pathologists, because that's so critical to the overall success of the patient, with your hand and with their hands together in it. I mean, that wasn't part of your vision when you started, was it?
No, absolutely not. Actually, I went to Perio because I never wanted to see a child under 18.
See?
And everything has changed, the whole paradigm and everything else. And thanks to Kevin and Len later on, meeting you, it changed my life and my whole practice.
Yeah.
And I met all these wonderful people that they're here today, or a number of them, including Samantha. So it's been an amazing. Kevin Boyd says we have a bright future ahead of us.
And so the key here is that take advantage of the community that you're part of, and lean on them, ask them, get reinforced when you run up against the barriers that are thrown in our way when we're trying to make differences in our profession. So that's the key, because it doesn't matter that our professions are resisting what we want to do. That's been true for the whole time. Physicians don't want dentists involved in this. Many dentists don't want to bother with this. Many hygienists are more focused on, what they were trained to do and not really interested in branching out. Speech and language pathology now is some of them are fighting back. I mean, it's just there's always divisions when we're trying to do something new. But I believe that we all understand how important this is and how much this addresses the big picture of human health and growth and development and the fact that the impact that we can have. And so good for all of you guys to be part of all of this. It's amazing for that. And then, by the way, we haven't said this yet, but I don't treat children. I never have treated children. I treated children reluctantly in my dental practice. When they needed behavioral guidance, I had no tools, and so I sent them off to the pediatric dentist. Right now, I don't treat kids. I don't do anything about what you guys do. But I've never released a tethered oral tissue. I've never provided a orthodontics. It's something that I believe in so fiercely that I want to gather around me the people who can do that. And my job is to pave that way, I guess, open doors, make it possible for the visionaries that come together with this in this movement to make it happen. So that's kind of my role on that one. So, anything
Okay.
else, Samantha, you want me to say before I start the?
I think we're ready to jump into what you have to share in terms of the technology. And I think it would be nice if you all want me to do this behind the scenes to, Barbara Green is here. She's been doing myofunctional therapy for 54 years. One of her kind of bones to pick is that the community needs a better connection point so we can see all of your contacts, and if you want to put that in so you can kind of have more connections with each other, I can put up a Google sheet, not to distract from what Steve has to say at the end, and you can just take that and enter in your information. And that's kind of the point of us gathering, because we really do need each other. I mean, at the end of the day, it's a lonely battle if you're just on your own. And if you see someone in your area, even getting together and having a coffee or something, that would be kind of the point of why we do this. So I'll put that up at the end. So I don't want to take away from what Steve has to say, but I think it would be good for all of us.
So I gave this talk was it last weekend, Samantha? 2 weekend? Recently in Chicago. And so
I think it was last weekend.
it was, yes, I believe so.
Mhm.
And so she said, well, can you help? I'd like for you to be on Coffee Klatsch. And of course, I've talked to Samantha about Coffee Klatsch for a long time. And I said, sure, when? She said, how about this week? And I went, okay, I can do that because let's do this.
There's
So
another skill, which is pivoting quickly. That's really high in my book. Yeah.
and so the talk I gave in Chicago was about technology, because one of the things that we're curious about is how do we know what's going on with kids? And there it is. And so disclosures, I need to make sure you guys know that I've talked for a lot of industry. And so if you like Google search a history, you'll see me connected with tons of industry out there because industry pays for speakers. My interest is only in getting people to be able to see the kids and adults in their practices. And so I educate dentists about that from lots of different avenues. I am chief dental editor of Dental Sleep Practice magazine, but nothing you're going to hear today has anything to do with like me making money or sales or anything like this. I did co-write a book, and I've contributed chapters to several other books so far. All right, so why do we want to know about objective measurements? And that's something that's really interesting for clinicians to know. Kind of what did we start with? What do we end up with at the end? And how do we measure these things in meaningful ways? Because so how do we know what we did had a big impact? And then you need a plan about how to use some of the technology here. And why do we need technology when we're talking about sleep-related breathing disorders for kids? Now, I understand what you guys do is a wide range of things with a function of the upper airway musculature and all the head and neck issues. That's not what I'm going to talk about. But I'm going to talk about uh, obstructive sleep apnea in some ways. Now, I could talk a long time about why obstructive sleep apnea is not really an appropriate label for what we do with kids, but research and physician world, the part of the definition, the part of medicine that tells us the area that we're discussing is framed by the language of obstructive sleep apnea. And the reason why that is because it began with those overweight old men in hospitals and expanded into the general population, but it was really only expanded into the adults. And physicians came around and said, well, wait a minute, kids have breathing problems too. And they started using the same rules, the same definitions, the same testing means to test a 4-year-old that they did a 40-year-old. And they have since realized that a little bit, let's say, that this isn't really very appropriate. But when we start looking at policies and protocols and definitions and kind of their lens, then it's still the language of obstructive sleep apnea. Now, I believe, and I firmly believe this, and there's good reasons to believe this, that obstructive sleep apnea is not the entity that we need to worry about in children. But when you see OSA on my slides, when you see quotes, when you see pulls from the literature that say obstructive sleep apnea or sleep apnea, it's going to be because of that framework. So Dr. Ghazal, he was there in 2018. He's one of the leading sleep physicians in the world. The distinctive symptoms of obstructive sleep apnea in children are scarce and usually require a high level of suspicion or a systematic implementation of screening questions to enable their detection. Notice the language there, and this is the guy who helps define things. He didn't talk about tests, he talks about screening questions. Why? Because tests don't work all that well, but mostly we need this high level of suspicion. If you've ever experienced going to a medical provider and them telling you the words, oh, we'll just watch this. Oh, they'll grow out of it. Oh, it's not really that important because it won't be there later on. Something to that effect. That's how most sleep physicians dealt with children for the longest time. That's how most pediatric physicians and all of dentistry thought about
Yeah,
breathing problems. But what we have to maintain is this high level of suspicion because even kids with risk factors and a disease that can be detected by some level of diagnosis have long periods of normal sleep. So you ask parents about how does their kid sleep, and they go, well, it's fine. Because why? Because when they walk in there and check the kid after, going to sleep a little while ago, then everything seems fine, especially if they don't know what to look for. And so the answer is going to be, oh, yeah, it's normal. So we have to be careful. So our perspective must be high level of suspicion. We have to think that nearly every child has some level of problem, especially if we're also noticing the things that we're trained to see, like structure, or function. And we know now that a misshapen upper airway structure or a improperly functioning upper airway musculature is a hallmark and sign that there's either been a problem or there's going to be a problem, or more likely both. And so we have this perspective. We want to find those children. So we must maintain a high level of suspicion. However, the parent's perspective is that they don't really want their kid to have a problem. No mother wants their child to be compromised. They don't wish to find issues there. But our role is to help connect behavioral problems, which is the easiest to identify, easiest to recognize, with structural and function problems, which take us to look at. So how do we identify behavioral problems and lifestyle problems? We just use simple technology like questionnaires. And there's a number of those out there. A few of them are I'm Sleepy and Bears. Those are easy to use, very simple questions for families to answer. They talk about behavioral issues, and our goal there is to help them connect some of the things that they recognize in their children's behavior with actual need to evaluate for more important medical problems. And that's very handy to use for families because you don't need any training to do an I'm Sleepy or a Bears questionnaire. FAIR is 6+4. You've heard about that from Samantha, no doubt. And that's excellent, but it requires medical knowledge or dental knowledge specifically to be able to do things like measure a transverse dimension of the palate. Those things don't come easily to somebody who's not used to looking in the mouth. And so it's difficult to even get our pediatric physician colleagues to look at this. And if we think about a sleep physician looking at this, that's just not going to ever happen. And then we have the pediatric sleep questionnaire, which is fantastic, but it's 23 questions, which is great. But if you are interested in introducing this to a hygiene visit or introducing this to a busy pediatric practice where children are in and out, in and out, in and out all day long, to say to the parents, please fill out this 23 question questionnaire and then we'll talk about it. That's a big impediment to the workflow. And so at first, it's a difficult place to go. Now, if you're a practice like Dr. Nahadas or Dr. Boyd is intent on discovering these kind of problems in your practices, then PSQ is our validated questionnaire. So that's important. CGASP project, and please, if you are interested in this, I'm going to describe, then take a screenshot of this one, take a picture with your phone, go to that QR link. And what this is it's the outcome of our 2018 Roundtable Conference. We voted at that conference with all those experts that what we needed was a validated, simple questionnaire. I'm Sleepy and Bears are unvalidated, which means that they don't have any literature behind them, which means that medicine doesn't pay attention. So our goal is to validate a simple questionnaire. This has 5 questions, takes 3 minutes, doesn't require extra training. And what it does is it indicates whether a child's at risk for breathing problems and therefore should be evaluated more thoroughly. So it's a simple screener. What we're doing with this part of the project is we are getting clinical information from as many offices as we can, and that clinical information will create a bounty of evidence that we can then go to funders and do what we have to do to get it actually validated, which is to put 400 kids through sleep tests, which is burdensome and very expensive. And so we're trying to find ways to make that happen. And so if you want to be part of our pilot project, then please join us with this QR code and you'll get information from it. There's no obligation, there's no cost. If you sign up, you have to do some things in your practice that are real simple with 5 questionnaires. So the trouble we have with thinking about children in the same way that we think about adults is that they are sent through polysomnography. Polysomnography is a 20 lead or so data collection setup made for adults in sleep labs. Well, they apply the same technology to kids. And that's my business partner's daughter there, Sydney. And look at her all lined up. Sydney doesn't look happy here, and most kids aren't happy when we're doing this. And the other problem we've discovered over time now is that when we consider how children respond to these tests that are made for adults, is they don't respond the same way. And so the way that the data collection is interpreted is wrong. We're not actually discovering problems in these kids that we should be looking for because all they're looking for is downstream breathing problems and the effect on the physiology. Nothing about a polysomnography has anything to do with the function of the upper airway or the structure that surrounds it. And on top of that, out of about approximately 5,800 sleep physicians accredited by the American Board of Sleep Medicine, there's only about 270 in the country, in the membership, which is worldwide, but mostly United States. There's only about 270 that are pediatric trained. And so it's really not enough for that. So in your community, you may not have anybody that has special training in pediatric polysomnography. So that means that children who are deemed to be at risk are sent to a adult-oriented kind of a program, and the technologists and the sleep doctors that are there may not know how to manage children very well. And so imagine that with all of that going on the kid and sleeping overnight in a strange place, how accurate, how reliable is that data? So what we've done is as technology has allowed us to measure different things in adults at home, then some of the technology companies said, well, I think we can measure kids too. And the FDA, who has decided that 3 of these are appropriate for children under 2. 2 of them, apnea track and NOx T3, are just traditional adult sleep medicine measurement devices called polygraphy, so multiple channels overnight. And very, very good data comes out of those. Generally, it's much better if you do more than one night. And depending on lots of issues, we might be able to do more than one night. We have something called sleep image, which is a ring that goes on a finger, and that one gives us really good data there too. The problem is that even the tiny one that they make for kids is bigger than most kids' fingers. And so it's trouble. We have a little trouble gathering proper data out of it that way. And that's all we have. And then we have a couple that are approved for more than 12 years old. But as we all know, and what you guys have learned over this bunch of coffee clatches, is that greater than 12 years old is way too late to start recognizing these problems, because we're past the age of influencing the function to the degree that we can when they're 3 or 4, and certainly not the structure like we can when they're growing. So those other 2 ones are approved, but not as useful for kids. So here's a new one I found when I was preparing for this lecture called Smart Care by Gabby. And I don't know anything about it except it has a similar technology as Sleep Image. And so that software is excellent. The Sleep Image software is really good. And this one goes around a forearm. Honestly, I haven't had time to look and see, okay, how reliable is the data that comes off of a forearm or a upper arm band, but it's on the market and it's FDA cleared, so it's got to be something that's valuable, and it might be much, much easier to use on an upper arm than it is a finger for a child. So cone beam technology is something that many of us are using now to assess the structure of the upper airway. And for little tiny kids on my iCat Flex, for example, we can dial that down to where it's a very tiny amount of radiation that gives us a huge amount of medical and structural data. But if you're going to interpret CBCTs in your practice, I believe this text is pretty mandatory. Dr. Tamimi has put together a huge book of resources there, and I think that that's a valuable addition for that. Full disclosure, I did write some chapters in that book, and so once a year I get dinner paid for by royalties off that one. So that's it. So what are you really looking for is, who do you have to convince? Now, you might think, okay, you have to convince the parents that the child has some kind of issue, and so this should be looked into. But you also have to convince sometimes the other parent, if there's a split household. Sometimes you have to convince the pediatrician. Sometimes you have to convince the pediatric dentist if you're a family dentist and you're not handling the kids and you're talking to mom in your practice. Sometimes you have to convince the speech language pathologist. You have to convince the many people sometimes that there's something to be worried about here. And that's the big goal. How do you paint the picture? How do you create the whole scenario that anybody in healthcare, anybody who cares for that child, can look at and go, okay, this is important. And what else should we know? How many other questions can we ask? What is the child's behavior through the daytime? How do we deal with this? What are our possible choices? Do we need more diagnosis? I mean, there's lots of things that we have to consider when we think about technology. And we also have to be able to see, okay, if we measure it this way, and then we apply some kind of therapy, whether that be an ENT for a tonsillectomy or a myofunctional therapy course of treatment, or a set of expanders for the palate. What happened? How did it change? Did things improve? And that's important when we're going to be able to help justify kind of the time, energy, and money spent on these therapies. And to be able to apply the treatments that we do with integrity as healthcare providers, what we always have to keep in mind is that are what we are proposing, what we're willing to work with a child for, we're willing to accept money for, what we're willing to ask the families to commit to, will it really change the child? Will it improve their health? Will it make them better? Will it relieve the kind of suffering that we see around us all the time that nobody else is addressing? And that's, guys, where I think that dentistry and hygiene and speech and language pathology and myofunctional therapy, the whole wrap up of addressing children's structure and function as early in life as we recognize it, I think that is encapsulated in the reducing suffering part. I don't think there's enough emphasis placed in assessment on actually the suffering of the child, the suffering of the families, when there's a compromise to these kind of functions and structure. We talk about what we can measure in medicine. We talk about oxygen levels. We can count how many apnea events they have and come up with an index. We can quantify some of the things that we can measure off of a ring or even an overnight polysomnography. But what is left off of the kind of assessment that I think is critical is to talk to the families about what's going wrong here. And one of the reasons I had Dr. Crabtree, the psychologist who wrote the book about pediatric behavioral sleep problems, there was because in her book, she wrote the phrase, well, ask the families what's going wrong because of these breathing problems. What's bad for you because your child doesn't sleep well? And we consider that the child has trouble maybe at school. Maybe they wet the bed longer than they're supposed to. Maybe they have lack of emotional control. But we can never dismiss the fact that that child who doesn't behave well because their brains can't behave well, we can't dismiss the impact it has on a family. So reduced suffering is not just about the patient that we're dealing with. Reducing suffering is reducing suffering for the entire family. And sometimes that family is a large family, a community almost. And that impact that we can have by paying attention early with something as simple as an I'm sleepy questionnaire, something as simple as being curious about why that child can't sit still in a chair, being curious about what the behavioral aspects are that you are able to ask questions of because you maintain a high level of suspicion. Being all of those things combine to make a difference. Because in medicine now, in dentistry, I mean, it's focus has been for the longest time on prevention. When I joined dentistry and well, I graduated in '83, but we were talking about how important it was for fluoride and how important it was for checkups because we just couldn't think it was okay to have children grow with a mouthful of cavities. I mean, that's still true today. When we see these tragedies where children haven't been taken to the dentist or they have a bad diet or there's a lack of education in their family that talks about dental health, and we see these unfortunate children with these mouthful of cavities. But what we have to embrace as a profession is that it must be unacceptable for a child to have an underdeveloped airway the same. And the medical consequences of not being able to breathe well because your structure didn't grow properly, because your muscles didn't force that bone to be a proper shape, because you didn't develop the kind of habits of nose breathing that go along with general health. That area of focus is ours. That's what we can do as the healthcare providers most impactful in the young ages. And leave it to our pediatrician colleagues to help them with acute problems, infections, and things, but leave it to us to help pay attention to craniofacial respiratory complex and make the truest difference in long-term health span for these little ones that we identify to have these issues, maintaining a high level of suspicion in our practice about what questions should be asked, what suffering can we relieve. That's what technology gives us. And simple ways, complicated ways, but really it's to help us focus. So Samantha, that's my little short talk.
I love it. And I think there's a lot of room here for everyone to kind of weigh in and from their own perspective about some of these challenges. Because I think that is kind of our collective challenge as we see and make these connections. And I love what you said, Doris, in the chat about it's not really hard for us to see these behavioral connections, but the communication to parents and then them taking it to physicians can be where a lot of this information gets lost. Or then it becomes almost like a blame game. Nobody was looking out for this, and they come into their pediatrician or feeling kind of angry about what was missing. Do you have any kind of insights into the best way for somebody to say, let's talk? Tell us what you would recommend, Steve, if these kind of issues come up in the clinic. How do you talk to the parent to go to get the next level of care?
Well, I think what the first step is to help the parents explore what they've noticed and start to help them put the dots together. Because, for example, an easy one is enuresis. If the child is wetting the bed longer than should be expected, then, that conversation is not typical in a dental office. I mean, you don't really need to know that information to take care of their mouth and teeth. But if you bring that up, and parents says, "Oh yeah, we talked to the pediatrician; they'll grow out of it," is what we heard. Well, I also notice this, and bring up a dental thing like a structure, and try and draw a line between behavioral issues and structure and function issues that we're expertise at. And so get the parents to ask questions. And then you can provide them some resources. There's a number of good books out there, um, that have been put together to help bridge that education gap between what's observed and what by the professionals and what's observed by the families, and help them realize that's part of a dysfunctional issue, and the dysfunction in the biggest way of using that. So really, it's about raising awareness, about opening eyes, about connecting dots.
What do you all see in your practices in terms of the gaps? Is it I'm actually quite curious from your clinical experience, and this is really open to our group here. Go ahead, Milt.
Okay, I got my audio on. Well, first of all, I want to thank Steve for everything he's done and through the ADA. Steve, I know you realize, but maybe not to the full extent, how much you've helped all of us getting the most official dental organization, the American Dental Association, for the past 8 years to even support and accept talking about those things, especially when it comes to children, not only adults. So, and you brought the best people on this together for all of us to learn from. You have been able, I believe it was last year that the president of the ADA was there. This year, the president of the AO was there. These are amazing things that these people would have never been, I don't think, to any other meeting that had to do with pediatric sleep, unless it was the one sponsored by the American Dental Association and by using you as the person that's well respected by the dental as well as the medical community. So thank you for all of this, because it couldn't have done without you. The only way that I can reward you for this is some Greek food, and that's all I can do. So thank you. Now, in Chicago, we've been able to really have a great group of people, but it took a long time to bridge the gap between physicians and dentists. And it's all in the approach, because for the physicians, what we do, especially, when you talk about tongue ties and lip ties, is the hardest thing, right, for physicians to even accept. However, when you're talking about pediatric airway and pediatric sleep, they're interested, but they're not interested in you approaching them to ask for referrals. They're interested in knowing how you can help them, or why is it good for them. If you approach them what it's good for you or your practice or the patient, they will shut you down. I can tell you this right now. So the best way to approach the physicians is mutual patients that end up with a pediatric ENT or the pediatrician or whatever. And you have to connect with the pediatrician, regardless if they like what you do or not. But the whole point is why what we do in dentistry that they may not be aware or they have the wrong information is good for their practice and their children. And we all put the child in the center. So don't go. I have, even as a periodontist for years before I got involved with this, I have never asked for a referral from a physician or anybody. I just want what I do and what my patients say back or the parents to the physician for them to accept what I do or even seek to talk to me or send me a referral out of nowhere. So asking for referrals, in my opinion, is not, everybody's different. But in any case, when you start making and bridging gaps with the medical community, because we all care about the same thing, then one brings the other and so on and so forth, and they give you the opportunity to do that. And from what I know, pediatric sleep physicians, like Darius Lokmani that we work with, the first thing he's going to tell you is they're so backed up on having sleep studies done that if anything a dentist can do is to get that child off their list, they would love you. So they're very acceptable to that. So don't hesitate to reach out to them because a lot of times they would listen because they don't want those kids to wait for 8 and 10 and 12 and over a year sometimes just for a sleep study to confirm something. And a lot of times they're, for what Steve said, those are very hard to do on kids and to be really meaningful. So that's it. That's a short part.
Great point. It's a great point. Eyal Boatser.
Hi.
Hello. Do you want to
Hello.
introduce yourself? Not everybody knows
Yeah.
what you
I mean,
tell us about yourself,
uh,
Eyal.
I'm a pediatric dentist from Israel, and I've been dealing in this field of tongue tie, which we were never taught about since 2000. And then my youngest daughter was born, of course, with tongue tie, so we struggled. And slowly, with research, we managed to get my understanding today on tongue tie and this amazing group. I think we have an earlier stage to intervene, and this is where the ADA is so important. And this is the education phase of all professions. Start in dentistry, maybe a core curriculum, maybe in medicine, because myofunctional therapists, this is what you learn from day one. But dentists and doctors, they learn nothing about it, and they just learn about the problems. We need to teach about the prevention, and it should be starting in the dental school and the medical school way ahead before they go out and start getting spoiled by the busy life. So if anyone who is affiliated to any kind of university, this is where we need to drill into the heads of the educators and get regular courses on the topics. That's all.
Dr.
Thank
Botza,
you.
that's excellent information. But the dental schools are guided by something called Council on Dental Accreditation, CODA. Until we get it in CODA, it's not going to get into the dental schools because they live their curricular lives by what's required from CODA. When they have accreditation visits, it's how are they complying with CODA. It's not about what else are you teaching, and so it's challenging, but it's people are working on that. I've heard from a couple of people now recently that have insight into CODA or maybe even some influence in CODA, and maybe we'll get that in there pretty soon. Get that pretty soon, probably a bad word. We'll get that in there eventually, and then it'll start to be into dental schools. That's going to be the key right there. And one of the things I want to bring up too is our friend Michael Simmons on this call is one of our best thinkers in all of this. And he does point out that some kids actually do outgrow this. Some kids do actually don't develop disease because we don't have a way to predict. And if we consider what we're doing in little ages as prevention, then that's really the wrong term. Because to be able to prevent a disease, you have to be able to draw a straight line between what you observe today that you can influence and what would happen if you don't do the influence. For example, if we have poor diet, high carbohydrates and lots of sugars, we can draw a straight line between that and caries development. We can prevent that caries by doing something like reinforcing the enamel with fluoride or changing the diet. That's clear prevention. Since we don't have a straight line between a child who doesn't breathe well at 5 and cardiovascular disease at 50, what we have to think about is proactive intervention. And proactive intervention means that we diagnose a problem. And our problem that we diagnose is lack of proper function and lack of development of the craniofacial respiratory complex. We don't have to concern ourselves with obstructive sleep apnea in kids. We do what we do. We're the only part of medicine that can assess the structure of the upper face, the upper airway, and the function of those muscles. So if we do that and help to establish and maintain the best structure, the best function, and we can only do this together as structural people like orthodontists and pediatric dentists, as functional people like speeches and myofunctional therapists. So we do this together. Now we're letting that little physiology have its best chance of growing up to be the healthiest it can be. So we're not treating obstructive sleep apnea. We're not preventing obstructive sleep apnea. We're proactively intervening where we identify a problem.
Interesting. I like the semantics become really important in how we share and assess what our impact is. Joy, did you have something you want to say? And I know Eyal, did you want to respond? We'll come back to you. Eyal, go ahead.
I'm sorry. So, well, I have some things to say. That we are getting a course in the Tel Aviv University Faculty of Dental Medicine School, at the Tel Aviv School of Dental Medicine. Next year, we're going to have a core curriculum on oral function, which has never been there. And the other thing is that we do know where the parts of the chain are connecting. We know that a child that is not breastfeeding has issues with palatal width, with orthodontics, and so on. So we need to connect those small pieces of chains that are existing. And thank you.
Joy?
I just wanted to say, I love your comment, Yigal, about schools, because that's been my passion from day one, is to go out and adopt a school. We can't wait for all the things to be perfect to get it into the curriculum, but everybody here went to school. So if you can, go to that school, do a lunch and learn, get some slides ready, and go out and teach them that this is available, even if you have to buy pizza or whatever.
Not pizza.
Well, something healthy for
Greek food, much better.
Great. Yes, but we can do that now. We can go to the PTA. We don't have to wait for the children of the dentist or the physician, because that's not going to happen fast enough.
Well, Joy, that's kind of been your MO, and you've been pioneering and spreading the information. That's why you, Barbara, and these Lori and Trish O'Hare, I mean, these pioneering is really getting into the trenches. I do think that has really advanced base knowledge. And now we have social media, which has a kind of double-edged sword, because some of the information isn't always accurate and it's a little sensational, and it might even put what we're saying into, I would say suspicion, to bring it back. So we do have even more of a reason to get out there and make the relationships and not just broadcast the information. I think the relationship building is at the core of this. Barbara, we have just a few minutes left. Go ahead.
I'm concerned at seeing a 3-year-old yesterday. He has such grossly enlarged tonsils. He's not sick a lot, but he's a mouth breather and he's using all of his musculature incorrectly. But what worries me is that this child is already so volatile And, you know, the whole time was spent correcting him and getting him under control. And then the mother becomes reactive. Then the child is reactive. It's like, it was like by the time they left, I needed to go to bed. It was horrible. And this is going to carry into when he goes to school. And this is going to carry into how he becomes as a human being. So it's not just what's happening to his bite. It's not just what is happening because he's a mouth breather. And the mother was told, fortunately, by the ENT that he should have his tonsils out. But she's fighting having his tonsils out. So and I told her, she said, can't you help him anyway? And I said, no, I cannot. The tongue has to have room to function. When you've got huge tonsils, the tongue cannot function properly. So no, I cannot. And either can anyone else that you might contact. So any of the 111 people here that she could contact, if somebody wants them as a patient, they'll take them on, but no one will be successful until that huge wad of tonsils are removed. So I get very upset with these parents also. Well, it's surgery though. Yes, it is. But so his life is being, you know, he's whiny in the morning. He's irritable during the daytime. He's temperamental all the time. So it affects their entire life and the life of the family.
I think that's why, Steve, in your gathering of the professional psychologists, you know, have been such a big part of this, because the self-concept and the relationship that's established and the dynamics in the family, that really carries into all domains. And I think we understand that here. I want to just close out what we are doing here, which is advancing the way that we're talking about this. And also just honestly, please put your name on the contact sheet, because, you know, you getting together, I mean, relationship building is really how we can move forward. And so I hope that's going to be one of the immediate outcomes. Someone is in your area, you know, getting together with them, bring them Greek food. We heard the power of, of feta cheese.
Mexican food.
And Mexican, I'm sorry, of course.
Ole, Huachinango.
So don't just put your name and your address, put where you are, and put something about yourself.
Yeah.
Form a community. Tell us one thing about, Jenny will say, I cook Mexican food, you know?
Right. Oh, I think, you know what? I'm adding a column. Okay. I'm going to add a column. It's fun fact.
There we are.
I also dance salsa, so there you go. Steve,
All right.
gracias.
Absolutely, everybody. I really appreciate you coming here, Steve. Thank you so much. Your leadership is rippling out. We need the leadership, and what you're doing is we need that. And you're really stepping into the light so that we can help and provide the answers. So we all appreciate that. Thank you, everyone, for being here.
Bye, guys. Have a great
Bye.
Saturday.
See you next time. Okay. Bye, everyone.